Okay, a very good evening, ladies and gentlemen. Thank you very much for joining us. This is our next installment of Cancer and I. And we've had an interesting set of sessions so far, starting from February. This set of series has been running in conjunction with World Cancer Day, which kicked off on the 4th of February this year. And then we're going on, and we're traveling every session virtually. So I think last week we had the opportunity to go a little down south to our colleagues from Malacca. And this week, we're very fortunate to have with us three very eminent physicians from up north. So you would say in Games of Thrones speak, the kings of the north. Uh, and I'm very honored and privileged to be able to introduce to you three of these very interesting physicians who will share with you very, very important highlights, very interesting topic, especially for women tonight, which is why I think we've crazily called it Ladies' Night. So pick up your glasses, non-alcoholic, of course, and sip on your virgin mojito while we kind of listen and gather some important insights. So this evening, we are very fortunate to be able to be partnered with Penang Adventist Hospital. And this is a hospital in the state of Penang, and they're very active in treating a whole lot of cancers, especially from people around the northern region, and actually not only from the northern region, from all across Malaysia and the region as well, Southeast Asia. And this evening, our first speaker will be Dr. Kylie Loh Wei Jen. And Dr. Kylie is a consultant medical and breast oncologist. And we're going to speak to Dr. Kylie in a minute. Good evening, Dr. Kylie. How are you?
Good evening. Thanks for having us here.
Oh, thank you so much for joining us, Dr. Kali. Such a privilege for us. And Dr. Kali, right off the bat, because we've had a couple of questions on this morning on the Facebook and some of the WhatsApp groups. What is a breast oncologist?
Right. Okay. So an oncologist is a doctor that treats cancer, and as cancer becomes more and more complex with ongoing research and all that, some of us subspecialize in a particular field. In my case, it is breast oncology. So I treat patients with breast cancer, essentially. Yeah.
Excellent. Thank you so much, Doctor. So, ladies and gentlemen, very privileged tonight to really get it out from the horse's mouth, so as to speak. And Dr. Kylie, who is a breast oncologist, the expert on breast cancer, and he's going to be speaking to you on a very, very interesting topic, which is triple negative breast cancers. Now, for a lot of us, we actually are very confused about what triple negative breast cancers are. And, Dr. Kali will speak to us a little bit about that as well. But for those who was sometimes in the know, we are often indoctrinated with this positive, negative idea. So you mean one negative, bad, two negative, worse, three negative, IO, dialo, So to shed a little bit of light today on this is Dr. Kylie. So I'm going to turn the stage right over to Dr. Kylie and then let him kick off the evening, and then we'll take some questions for you as we come along. Dr. Kylie, the stage is yours, sir.
Sure. Let me just share my screen. Yeah. Okay. Can my slides be seen?
Yes, they can, Doctor.
Great, great. So thanks, Dr. Murali and National Cancer Society in Malaysia for having me on the Cancer and I series, and for tonight, the Ladies' Night. So I'll be covering the topic on triple negative breast cancers. Before we dive into triple negative breast cancers, it's important to understand what is triple negative breast cancer in the context of breast cancer as a whole. So we know that breast cancer is the #1 cancer amongst Malaysian women, as well as in other countries. Unfortunately, it is rising in incidence, and the type of breast cancer does matter, as the the prognosis and how we treat these patients do differ by the different subtype of breast cancers. So there is no one size fits all approach for breast cancer. The good thing as well is it is highly treatable, especially when it is picked up earlier in the phase of the disease. And this is also owing to regular advances in the treatment options, as well as the diagnostics that we have to sort of personalize care to every breast cancer patient. Now, this is just a very simplistic view of the types of breast cancer. So most women with breast cancer will have hormone receptor positive breast cancer, so about 70 to 75% of women. And this is characterized by the positivity of either the estrogen receptor plus or minus the progesterone receptor. Now, in general, hormone receptor positive breast cancers are mostly well-behaving, but the caveat is we do also see some subtypes of hormone-positive breast cancers that can behave badly. Secondly is HER2-positive breast cancer, which constitutes about 20 to 25% of breast cancers. Now, this used to be a very bad cancer to have, but because of the very good treatments that we have now, the prognosis for HER2-positive breast cancer is actually really good. Thirdly is triple-negative breast cancer, which constitutes about 20% of breast cancers. Now, this is generally not a good cancer to have. It's a challenging cancer to treat. But with the right treatment, as well as picking up the disease earlier, the outcomes can also be good. In terms of treatments for the different types of breast cancers, it would generally depend on the stage of the breast cancer. But when we think about hormone receptor positive breast cancer, we have the option of chemotherapy, anti-hormone therapies, as well as targeted therapies. For HER2 positive breast cancers, we generally use chemotherapy and anti-HER2 therapies. And for triple negative breast cancer, we have chemotherapies and more recently immunotherapies and targeted therapies. Now, the paradigm of treating early breast cancers has evolved over the decades and more recently over the last 3 to 5 years or so. So traditionally or generally, patients will often present with a symptom that may suggest the diagnosis of a breast cancer. And they will usually have some scans done, like a mammogram, an ultrasound of the breast, plus some scans to check if the cancer has spread to other parts of the body. And most importantly, a needle biopsy to confirm the diagnosis of breast cancer as well as the particular subtype of breast cancer. Now, this is usually followed on by surgery. And surgery, there's an option usually for breast conserving surgery, i.e. to just remove the lump plus radiation in the future, or having a mastectomy plus or minus reconstruction of the breast. The second important part of surgery is the lymph nodes. Usually, if the lymph nodes if they are not involved clinically, as in it is not involved on scans or we can't feel anything in the armpits, patients should have a sentinel lymph node biopsy, as it will save patients from having their lymph nodes all cleared out and put them at risk of lymphedema or swelling in their arms in the long term. And after surgery, we will usually get a report from the pathologist that will tell us what is the stage of the cancer, what's the type of breast cancer, before we make a decision whether a particular patient needs additional treatments after the surgery. A usual question that will come from my patients is, look, doc, I've had my surgery. Why do I need additional treatments? The cancer has been removed from my body. And that's a very good question. But the thing is, if we look back 50 years ago, surgery was the main modality of treatment for cancer. But what they found was the cancers, there were certain patients that still had their cancers relapse despite the best efforts of the surgeons. Now, this is because of the concept of microscopic spread of the cancer cells in the bloodstream to distant or to different parts of the body. When we give treatments in addition to surgery, whether it's chemotherapy, anti-hormone therapy, and so forth, this serves to eradicate the microscopic spread of cancer cells that may reduce the risk of relapse and improve the chance of long-term cure. Now, how do we know whether these microscopic cancer cells are there or not? So we can usually predict if they're there or not by looking at the stage or the burden of the cancer. The larger the cancer, the higher the risk of relapse, the higher the risk of having these microscopic cancer cells being around. And also the behavior of the cancer. So is this a cancer that behaves badly, like triple negative breast cancer or HER2 positive breast cancer? And in patients with hormone receptor positive breast cancers and HER2 negative, we can also sometimes do genomic tests that can look into the genetics of that particular patient's cancer to see if they require chemotherapy or not. So in patients who are found to be low risk based on these tests, we can safely omit chemotherapy in these patients. So after we sort of scrutinize the reports and decide what is the risk of relapse for a particular patient, we then administer these treatments to eradicate the microscopic cancer cells. Now, so this, as I said before, it serves to eradicate the cells to reduce the risk of relapse and improve the chances of cure. So this is called the adjuvant paradigm. So i.e. we do surgery first, followed by treatments after. After completion of the treatments, patients usually move towards the survivorship phase where we try to get patients back to their normal lives and to survey for any future relapses. So this is the traditional paradigm, and it's mostly applicable to most hormone receptor positive HER2 negative breast cancers, as well as stage 1 HER2 positive and triple negative breast cancers. Now, another approach is what we call the neoadjuvant paradigm. That means that we give these extra treatments before the surgery based on the information that we have from scans, from the initial biopsy. Now, when we do this, we buy some time for patients to do important matters like fertility preservation, doing genetic testing, especially in patients who are younger and who have a higher predisposition of a genetic condition that puts them at a higher risk of getting cancer in the future, as well as deciding what type of breast surgery you would like to have, because it's not as easy as okay, you know what, let's just remove the whole breast or remove just the lump. It's not as easy as that. After we finish the chemotherapy, patients move on to surgery where they can have either breast conserving surgery. And we must also understand that when we give chemotherapy or anti-HER2 or whatever therapies before surgery, we shrink the cancer down to a size where we're able to conserve the breast in more women. For some women, we still do a mastectomy, especially for those who are found to have a genetic condition based on their genetic test that puts them at higher risk of getting cancers in the future. We then follow on to the report from the surgery. If there is any residual or remnant cancer within the breast, This usually portends a poorer prognosis, and these patients will usually need further treatments to improve the chances of cure. And this is in particular the case for HER2 positive and triple negative breast cancers. And if there is remnant disease, then they will have further treatments to further improve the chances of cure before moving to the survivorship phase. Now, doing this allows us to give more effective treatments to patients who need it the most. And this is applicable to patients with large hormone receptor positive HER2 negative breast cancers that are not resectable, or for patients who want to pursue breast conserving surgery, as well as stage 2 and stage 3 HER2 positive and triple negative breast cancers. Now let's dive into triple negative breast cancers now. So essentially, they are breast cancers that do not express the estrogen receptor, progesterone receptor, and the HER2 receptor. They are generally more aggressive in nature, and they're also more common in younger women. And there's a higher likelihood of a genetic predisposition in the background, for example, BRCA1 and BRCA2 mutations. So no one sort of tells the story of BRCA mutations or genetic conditions and cancer better than the story of Angelina Jolie, who has a BRCA1 mutation. So these patients are at a very high risk of getting cancer in their lifetime. And for BRCA mutations, in particular, female cancers like breast and ovarian cancers. We must also say that most BRCA1 mutation positive patients actually have triple negative breast cancer. Now, this is a classic BRCA1 family pedigree. You can see that cancer affects multiple generations, and especially in women and female cancers here, breast and ovarian cancers. The treatment approach for triple negative breast cancer can also be quite different from other types of breast cancer, and we'll dive to it in the next few slides. Now, what are the treatment principles for early stage triple negative breast cancer? Essentially, faster is always better for triple negative breast cancer, because delays in giving chemotherapy is associated with poor outcomes and a higher risk of relapse. Most patients should have neoadjuvant chemotherapy, i.e. before surgery. So this is not very well known yet, and so it's good for us. It's good for everyone to know. For these patients, we need to give chemotherapy earlier, and in most patients before their surgery. So as I said before, early exposure to chemotherapy improves outcomes, by preventing early metastatic disease or early spread of the cancer. It allows time for genetic testing, especially since that triple negative breast cancer patients are at a higher risk of having a genetic condition. And if one has a genetic condition and puts her at a very high lifetime risk of breast cancers, she may want to have a mastectomy, and as well as a mastectomy on the other side as well, to prevent future cancers. Most importantly, by giving chemotherapy first and assessing how patients respond in their surgical specimen, it tells us if a patient needs to have more effective treatments like oral chemotherapy after surgery or not. It also allows us to downsize the cancer to allow for a higher chance of conserving the breast for women who choose to do so. Now, people often ask, is it safe to forego surgery for the time being and have chemotherapy? So i.e. is neoadjuvant chemotherapy as good as adjuvant chemotherapy, i.e. surgery followed by chemotherapy. So there are few large clinical trials that have proven that this is actually safe. And neoadjuvant chemotherapy is now the standard of care, especially for stage 2 and above, stage 2 and stage 3 triple negative breast cancer. Stage 1 triple negative breast cancers we can safely recommend for patients to have surgery first, followed by adjuvant chemotherapy. Now let's look at some cases to showcase neoadjuvant chemotherapy better. So this is Wendy, a 45-year-old woman who presented with a breast mass, and she was diagnosed with a stage 2 lymph node negative triple negative breast cancer. Now, she was referred to us, and she was counseled, recommended to undergo neoadjuvant chemotherapy, i.e. chemotherapy before the surgery. And during this time, we also recommended that she had genetic testing, as well as some time to think over what type of surgery she would like to have for the breast cancer. For her, she was commenced on a 3rd generation chemotherapy, in this case, AC by 4 and paclitaxel by 12. So this is jargon, but this is a pretty standard 3rd generation chemotherapy that we would give to breast cancer patients at high risk of relapse. And she achieved a very good and in fact a complete clinical response, i.e. we could no longer feel the breast cancer in the breast. There is also some emerging data that suggests that adding immunotherapy to chemotherapy in the neoadjuvant phase improves the response to chemotherapy, but the long-term outcomes, whether immunotherapy actually reduces the risk of relapse, is still pending. Now, in her case, the multi-panel genetic testing came back as BRCA1 positive. So she does have a very high lifetime risk of breast and ovarian cancer. So in her case, after counseling, she decided to have mastectomy on both breasts as well as a reconstruction. And considering that her lymph nodes were not involved in initial scans, she only had a sentinel lymph node biopsy. So fortunately, when we had a look in the breast tissue, there was no remnant cancer left. So this is what we call pathological complete response, i.e. no evidence of invasive cancer found within the breast or lymph nodes after neoadjuvant chemotherapy. With this information, we can tell her that, Wendy, your prognosis is excellent. The chances of long-term cure is going to exceed 90% for you. And considering she's done really well, she doesn't require any further adjuvant chemotherapy, and we can safely move her to the survivorship phase. The next patient is Mariana. So she's a 39-year-old lady who presented with a breast mass as well, and she was diagnosed with a stage 2 lymph node positive triple negative breast cancer. Similarly to Wendy, she was recommended to have neoadjuvant chemotherapy. And in her case, she was given AC by 4, followed by paclitaxel carboplatin by 12. We sometimes add on extra chemotherapy like carboplatin based on some studies that it actually improves the chances of pathological complete response. And we know that when patients achieve that, it is associated with better outcomes in the long term. As I said before, there is emerging data on the use of immunotherapy in addition to chemotherapy for improving the chances of pathological complete response, but the long-term results on whether it prevents relapses in the future is still pending. So in her case, we also spoke about genetic testing, considering that she has triple negative breast cancer and she's pretty young as well. And her genetic testing came back as negative. So she decided to have breast conservation surgery. And what was good was the cancer actually shrunk by quite a lot. And the cosmetic outcomes of the breast cancer surgery was pretty good. She also had her armpits cleared because she had lymph node positive disease at the very start. In her case, unfortunately, there was actually remnant cancer that was found in the breast, but the lymph nodes were clear of cancer. We know based on data and a lot of research that residual cancer post neoadjuvant chemotherapy is bad. And these patients will usually require further adjuvant treatments to improve their chances of cure, especially for triple negative breast cancer. In her case, she needed to have radiotherapy regardless because she had lymph node positive breast cancer from the start. But in her case, because of the residual disease within the breast, we would recommend for her to have capecitabine oral chemotherapy for further 6 months, which has been proven to significantly reduce the risk of relapse and improve the chances of cure in the long term. Now, if we did not take a neoadjuvant approach, we would not have this information on residual or remnant cancer in the breast after neoadjuvant chemotherapy. And we would have lost the opportunity to give her more effective chemotherapy to improve her outcomes in the long term. So neoadjuvant chemotherapy allows us to give more effective treatments to patients who need it the most and spare others who don't need it. Now, how about treating advanced triple negative breast cancer? So this is in patients who the cancer unfortunately has spread beyond the breast to other parts of the body. Now, this remains a challenging cancer to treat due to the limited treatment options in the clinic. But the silver lining is the treatment options that we have now are expanding due to greater understanding of triple negative breast cancer and the progress in developing new treatments for the condition. Researchers have also found that triple negative breast cancer is not one disease. It's actually different. There are different subtypes of triple negative breast cancer based on research, and we know that they differ in prognosis as well. But whether this impacts the way that we treat triple negative breast cancer is still unknown and remains investigational. Now, what are the key tests that need to be done if someone is diagnosed with advanced triple negative breast cancer? It is important to check for immunotherapy biomarkers, so like PD-L1, tumor mutational burden, and microsatellite instability. We should also check patients if they have a BRCA mutation or not, because these patients, if they are positive, they may qualify for certain targeted therapies. Now, in the old days, chemotherapy was really the only option for patients with triple negative breast cancer in the advanced stage. There were also clinical trials back then, but back then the results from clinical trials were not very encouraging. But in recent years, we have immunotherapy that has been added to the arsenal of treatments that we have for triple negative breast cancer. So there are actually 2 immunotherapy agents that have been approved for use in triple negative breast cancer. The first one is atezolizumab in patients who are PD-L1 or positive, and it must be combined with a chemotherapy called Abraxane. The second immunotherapy is pembrolizumab for patients who are PD-L1 positive, and it should be combined with chemotherapy as well. But there is also good data to suggest that pembrolizumab is also effective in patients who harbor a high tumor mutational burden, or MSI, or microsatellite instability, which can be checked for with next generation sequencing of the cancer itself. For patients who are BRCA positive, we can use a targeted therapy called olaparib, which is in a class of drugs called PARP inhibitors. And more recently is a drug called sacituzumab govitecan. So it's a mouthful. And what is it? So it is actually an antibody drug conjugate. Essentially, they bind chemotherapy to an antibody here, okay, and this antibody is engineered to bind to a particular protein on the cancer cell called TROP2. Now, TROP2 is actually very commonly expressed in triple-negative breast cancers. In fact, the data shows that about 90% of triple-negative breast cancers express the TROP2 protein on the surface of the cancer cell, which makes it an ideal target for an antibody to bind and to deliver the chemotherapy into the cancer cell. So this is like targeted chemotherapy. So this was approved recently in the US. Currently, it is still not approved in Malaysia or Singapore as yet, but on special access schemes, we are able to bring this drug in. Lastly is clinical trials. So we cannot forget the importance of clinical trials, especially in challenging cancers like triple-negative breast cancer. Now, one is going to ask, how do we actually access clinical trials? So clinical trials are usually done at cancer centers across Malaysia and across the world. Triple-negative breast cancers, there are a lot of clinical trials now happening for triple-negative breast cancer due to the boom of immunotherapy for the condition. One way you can look for clinical trials is through a website called OncoShot. So OncoShot is a clinical trial matching patient matching sites. It's like Tinder for clinical trials and cancer. Okay, so this website was developed by a colleague of mine from National Cancer Center Singapore to give greater access to patients outside academic cancer centers to promising clinical trials. So if this is something that you would be interested in, you can Google OncoShot. The caveat is it's COVID season and borders are not open as yet. But once borders are open, then perhaps this can be an option for cancer patients in the future. So that's the end of my talk on triple-negative breast cancer. And perhaps we can go on to any questions that you may have.
Thank you so much, Doctor. I am really amazed that you managed to kind of, in that short a time, put together almost everything that we have around triple-negative breast cancer. Thank you very much. I think that's proven to be very succinct. So for some of the audience who are just joining us and you missed Dr. Kylie's kind of segment, please be sure to visit either the Penang Adventist page or ours at National Cancer Society, the Facebook, and the videos are right after this session they'll be on, so that you can take your time and re-listen to them. And I think it's a lot of information that is worth going over maybe even 2 or 3 times to help you understand better. So thank you very much, Doctor. Doctor, we have a few minutes. Are we able to take some questions?
Yeah, sure.
Okay, lovely. And some of this may be a bit repetitive, Doctor. So please feel free to kind of
Yeah, sure.
feel them. Okay, so there's one question on how do we diagnose someone with TNBC? And I think before deciding on treatment options.
Okay. So usually women with breast cancers present with a lump or or some kind of symptom in the breast. Usually this is biopsy, and through the biopsy, we'll be able to tell that this is breast cancer or not. And number two, we should do the ER, PR, and HER2 markers to see what type of breast cancer it is. So ER negative, PR negative, HER2 negative breast cancers are essentially triple negative breast cancers. So that's how we diagnose it. And it doesn't take long. It takes, 5 days to a week. Yeah.
Right. Doctor, I just wanted to kind of strengthen this point that you're making and ask you whether, because in some smaller centers, sometimes due to financial issues, patients sometimes opt to think about, oh, let's not do the testing at this time. And I think you've mentioned very clearly in the talk today how much that actually limits our options. Isn't that true, Doctor?
Yes, so because the way we treat breast cancer is very much driven by the type of breast cancer someone has. So at our center and also in my center in Singapore, the ERPR and HER2 is done right at the initial biopsy.
Right.
So that we can actually rationalize which treatment option is best for patients.
Right. Lovely, Doctor. So ladies and gentlemen, I think one of the takeaways that I think Dr. Kylie is kind of quite importantly mentioning today is always kind of make sure that the tests are done. If by any chance you are diagnosed, you are going for biopsy, have that discussion with your physician and
Yes.
and don't because sometimes people will be like, yeah, this is a couple of thousand ringgit or a couple of hundred ringgit, it's money that I could save for treatment. Yeah, but it makes a big difference, ladies and gentlemen, for treatment, and that's exactly what Dr. Kylie is saying as well.
The next thing that's really important is for stage 2 and stage 3 triple negative breast cancers to have the chemotherapy upfront before the surgery, because we can use the information after chemotherapy in after surgery to see if this person actually requires further chemotherapy or not. And we know that this makes a difference in the long term by reducing the risk of relapse.
Right. Doctor, just to kind of, because the next question seems to be related very closely to this, if I have metastatic triple negative breast cancer, how do I kind of decide which treatment is best for me?
Okay, so for metastatic triple negative breast cancer, there are a few important tests to do, as I said earlier in my talk. So firstly, we need to know whether you can qualify for immunotherapy or not. So you need to check for the immunotherapy biomarkers. They are called PD-L1 testing. And if those are negative, you can also check for TMB and MSI. It is also very important to check for BRCA mutations. And this is quite easily done nowadays, either through a blood test or even testing through the saliva. And the testing just takes roughly about a couple of weeks to come back. And for patients who are PD-L1 positive, triple negative breast cancer, the standard of care that will give the best outcomes is chemotherapy in addition to immunotherapy.
Right. Yep. And that's actually right away. That's the next question that somebody asking, which is how much of benefit will immunotherapy actually give to me? Will it improve? Will it make me live longer? How long can it extend my life?
Okay. So it's really hard to put numbers on someone's head. Okay. But of course, when we look at clinical trials, these numbers that I'm about to say are average numbers. So we know that some patients do even better than those numbers, and some don't do as well as those numbers. So when we give immunotherapy to patients, it extends the control of the cancer not by much, by about 2-3 months. Okay, and in some patients even up to 4-5 months. Okay, depending on how high the PD-L1 is. The other thing is the important part of immunotherapy is it extends survival, as in like what you said earlier, does it make me live longer? The answer at the moment is yes. Okay, and it is very hard for a particular treatment to eventually lengthen someone's life in the long term. There are many treatments for breast cancer or for cancer in general that actually um, prolong the control of the cancer, but don't actually change the survival in the long term. But immunotherapy actually does. And immunotherapy extends the survival by up to about 8 months more in the long term. So nowadays, patients with triple negative breast cancer, especially those on immunotherapy, are looking at an average of 2 years, if not even more. Some patients do better, and some patients don't do as well. But of course, we must always be hopeful, okay, that we are on the other side of the curve, okay. But at the same time, if we are not, then let's try to focus on things within your control. Sometimes having stage 4 breast cancer makes you feel like you're not in control. But believe me, there are also many other things that they are within your control, like spending time with loved ones, eating the meal that you actually enjoy, speaking to a long lost brother that you haven't spoken to for 30 years. So those are meaningful things that you are still in control of. So try not to focus so much on the numbers per se and draw the number on your forehead. And you shouldn't. You should, focus on the important things in life, and let the doctors worry for your medical condition, and to try our best to achieve the best outcomes for you.
Right. So so really, thank you very much, doctor, and for, as I was saying, the very insightful and interesting explanation on triple negative breast cancer, and also kindly kind of answering these various questions, ladies and gentlemen. As we wrap up your segment today, doctor, could I ask you if you want to leave our viewers with maybe one or two takeaways?
One or two takeaways. Okay, so triple negative breast cancer needs to be treated early. So don't don't ignore a breast lump. Make sure you see your doctor early if you're concerned about breast cancer. Triple negative breast cancer in general should have chemotherapy before the surgery, especially for stage 2 and stage 3 triple negative breast cancers. And do consider doing a genetic test because of the risk of a genetic condition in triple negative breast cancer.
Right.
Thanks, Dr. Murali.
Thank you, Dr. Kylie. I'm so sorry, but could we take just one more question, which I think is a very different one than what we've had so
Sure,
far.
sure.
Okay, and I think very sorry today, very panas lah your question.
It's okay, man. Yeah.
This one I think is from a survivor, doctor, and
Yes.
this viewer of ours asks, having gone through treatment for triple negative breast cancer 10 years ago, what are the chances of relapse? I did a mastectomy as well during that time. What are the options for follow-up as well?
Okay, so the good news is the chances of relapse in your case is actually very low. Okay, because triple negative breast cancers, if they are going to relapse, tend to relapse quite early on in the first 3 years, especially. So once you're past 5 years, generally the relapse rate is actually very, very low. Okay, unlike hormone receptor positive breast cancers, which tend to relapse beyond 5 years and even up to 20 years later. In terms of follow-up, the follow-up is mainly to check for any new breast cancers in the future. Because one who has had breast cancer in the past is at higher risk of getting another breast cancer in the opposite breast, considering that you've had a mastectomy before in the past. So all you need is a mammogram and seeing your breast surgeon on a regular basis. And when I say a regular basis, once a year is actually enough for physical examination. But of course, if you do feel a lump, don't wait for 1 year. Make sure you see a doctor earlier.
That's right. So thank you very much, Doctor. Ladies and gentlemen, that was Dr. Kylie Low Wei Jen, who was with us this evening, who is a consultant medical and breast oncologist from Penang Adventist Hospital. Thank you, Doctor. Good evening. And to continue with our second segment this evening of the list of speakers from Penang Adventist Hospital, we are very privileged to have with us as well Dr. Chew Gi Keng. Dr. Chew is a consultant gynecologist at Penang Adventist Hospital. And Dr. Chew will be with us this evening and speak to us about an equally popular topic, which I think is making waves everywhere, cervical cancer. Good evening, Dr. Chew. Thank you for joining us.
Good evening, Dr. Mari.
Such a privilege to have you with us this evening.
Thank you.
Dr. Chew, so this is another very hot topic besides breast cancer, cervical cancer. So the question really, and this is something the UN and WHO is pushing for. So my opening question is, can by 2025?
I think if we increase awareness and through programs like this, and also we have a lot of NGO programs in improving screening, I like to think, yes, we can eliminate cervical cancer by then.
Lovely. I mean, that was kind of the kind of opening statement from Dr. Chu, who's today going to speak about cervical cancer elimination and how we are going to get to it. So, Dr. Chu, wanted to ask you, where have you kind of chosen to focus on gynecology? Why did this happen? Why gynecology?
Okay, I actually started off doing obstetrics, and that was my favorite thing. But in the course of my treatment, they always say your trainer knows you best. Okay, and my trainers decided that gynec-oncology was what I was supposed to do. So I went along that way, and I can't say that I've regretted it.
Right. Lovely, doctor. do you still see a lot of cervical cancer these days?
Unfortunately, yes. And quite often in young patients who have not known anything about screening, who have had screening but not been given the correct advice. So some we've managed to detect early and treat and cure, but quite often, even very young patients in their 30s, we are seeing quite advanced cancers. So I am really hoping that actually we can do more and gradually just someday somebody's going to say, what is cervical cancer?
Lovely, doctor. We hope it goes the way of smallpox. And I'm just going to be turning the screen over to you, ladies and gentlemen. This is Dr. Chu, and she's about to speak to us about cervical cancer elimination. How do we get there? Over to you, doctor.
Okay, thank you. I'm just going to share my slides. Okay, right. You can see my slides?
Yes, I can, doctor.
Okay, lovely. Okay, so I'm here to talk about cervical cancer elimination. How do we get there? And I always think that it's interesting when some patients who come to my clinic who have cervical cancer or have just come for just a routine checkup, they have no idea what the cervix is. So talking about cervical cancer, I actually need to introduce the topic of what the cervix actually is. So I'm going to show you some photographs. Oops, my screen is not moving. Okay, about what the cervix is. So cervix is not visible to most people. And if you go and see a gynecologist, they will quite often be leaning down, peering between your legs, and you wonder what they're seeing. But actually, this is the cervix, okay? The cervix is at the end of the uterus, and it's only visible when you introduce a speculum into the vagina and open up the vaginal cavity so that we can see the entrance as it leads into the womb. So this is a normal cervix, and it is the cervix of somebody who's never delivered a child vaginally. And this is a variation of a normal cervix. So this is a cervix which has delivered a child before, okay? And on the white blob next to it is a blob of mucus. So actually that's not anything sinister, okay? So where is the cervix? Okay, in our pelvis, okay, we have the uterus. So there it is, okay? And at the end of it, that's our cervix. So as I say, if you introduce a speculum, we can therefore see the cervix over here. So next question, what does cervical cancer look like? Now, it can look like a tumor that is bleeding quite heavily. It can look like a tumor that is sticking out of the cervix. So there's the orange thing here with lots of blood vessels. It can be a tumor that has eroded and made a hole in the cervix. Okay, and here is a picture of a cervix that has been removed, in fact, the whole uterus, as part of our treatment. So in the center here, this is my hand, by the way, okay, and in the center here is the cervix, cervical cancer, and this is a rim of vagina, and the uterus is down here. So this is upside down. If I flip it the other way around, so this is the uterus, so that is the uterus. Sorry, can you see my arrow, by the way? All right. Okay, so this is the cervix here, and this is a tumor sticking out of the cervix. Okay, so this is what cervical cancer looks like, and we hope that not many people will get this if our campaign is successful. So cervical cancer is a preventable cancer. All right, so what it means is that we have the means to try and detect it before it turns to cancer. We have the means to try and prevent people from getting cancer full stop. But in 2020, we have 1,740 newly diagnosed cases of in Malaysia. So this really shouldn't be happening if this is a preventable cancer. Cervical cancer was the 11th most common cancer in Malaysia, so that includes cancer infecting both male and women. But in women, it is the 7th most common cancer. But in the women in the reproductive age, it is unfortunately the 3rd most common cancer. So this is what we're aiming to prevent. So how will you know if you have cervical cancer? Well, you bleed, okay? This is bleeding outside of normal. So this is not bleeding during a menstruation. This is bleeding outside of menstruation. So when you're not having your period and you continue to bleed, and a lot of times these women are bleeding almost daily, that is not normal. If you have sexual intercourse and you bleed after the sexual intercourse, again, this is not normal. But it doesn't mean that if you're bleeding, you definitely have cervical cancer. It just means that you need to be checked to ensure that you don't have cervical cancer. Cervical cancer is often smelly. So women have a very smelly discharge and they are socially embarrassed by it. And quite often they will socially isolate themselves from their friends, they won't go out, and it becomes a very lonely disease. And you know, my boss used to tell me, you can smell the cervical cancer before you see it. So it does have a very distinct smell. And in the later stages of cervical cancer, it can be quite painful. Painful during sexual intercourse, painful because it has actually spread to infiltrate the surrounding tissue. So in order to try and eliminate cervical cancer, we have to understand the natural cervical cancer, the natural history of cervical cancer. And we are very fortunate because the understanding of the natural history has come a long way. And most importantly, we recognized a very long time ago that before the cervix turns into cancer, we have a precancerous stage called the cervical intraepithelial neoplasia, quite often referred to as CIN, or some patients will call it Cin, right? So how do people get cervical cancer? Well, it has to come from having had an infection with this human papillomavirus. Human papillomavirus infection is a very common infection. And in your lifespan, 90% of women would have been infected by human papillomavirus. Now, the transmission of human papillomavirus is through genital contact. So it's through some sexual activity. So although a lot of people would have been infected by human papillomavirus, most people are able to recover from the virus and get better without any repercussions. However, in women who smoke cigarettes or who have an immunocompromised health, through repeated exposure to the human papillomavirus over a period of maybe 2 to 5 years, you can progress on to develop cervical intraepithelial neoplasia. But the CIN is not an irreversible state. So what it means is even though you have CIN, some women will get better spontaneously. But it will be better if we do detect this stage so that it does not progress to become cervical cancer. Now, this whole process from infection with human papillomavirus to development of cervical cancer takes almost 10 to 12 years. So we actually have such a very long time, lots of opportunities to pick out the cancer. So ideally, if we can pick it out when it is a cervical intraepithelial neoplasia, we can therefore treat it before it becomes cancer. But women with CIN look like this. They look like normal everyday folk who have no symptoms. Okay, so you are not aware that you have CIN. Okay, so the strategy to try and reduce cervical cancer has to be one where we can try and pick the disease up so that even though you have no symptoms, we can try and identify that you are at risk. And that goes through a process called screening. So screening is a strategy used in a population to detect a disease in individuals without signs or symptoms of the disease. And, you know, we have had screening for cervical cancer or even CIN as far back as 1940s. And that is in the form of the conventional pap smear. The pap smear is a test where we use a wooden spatula and we collect cells from the cervix, we spread it onto the glass slide, and then we send it to the lab and I hope the doctor can identify some abnormal cells from what we have sent. And this method has been quite effective in identifying precancerous disease to allow us to treat cancer and prevent, to treat the precancer stage and prevent the development of cancer. As time progresses, there is improvement in the way we collect the cells to make life easier for the doctors. So we have a different collecting method, which is using a brush to collect the cells and transfer it into a liquid medium so that the cells can be transferred on a monolayer in a slide to make it easier for the doctors to identify the abnormal cells. And this thing is called the liquid-based cytology and has been available for quite a while. I think we're talking more than 20 years. So this has been around for a long time, right? But yet we still have cervical cancer. We still miss cervical cancers, okay? So there has to be a better test, okay? And the better test is HPV testing. We know that cancer is caused by infection with HPV. We also know that there are 14 subtypes of this human papillomavirus that are associated with the development of cervical cancer. So these 14 subtypes are known as anogenital oncogenic HPV because there are HPV that affect the anogenital area which do not turn into cancer. So we are interested in these 14 subtypes and we have a test that can actually detect all 14 subtypes. And this test can be done in the same way we do a pap smear, or it can be done with a swab as shown in the photograph without having to introduce a speculum. This test is more sensitive than the pap smear because it will identify the women who've been infected with HPV and therefore identifying them as being at risk of CIN before they develop CIN. It also eliminates human error and reduces the subjective difference in the interpretation of the results. Most importantly, this test has what we call a very high negative predicting value. And what this test means is that it gives us confidence to identify those who are at low risk. All right. So we can reassure this woman that the chance of getting cancer or CIN is low, and then we can concentrate on those who are positive to try and treat them. So in a screening program, having a high negative predictive value is very, very important and beneficial. So how do we interpret this? We know that some HPV behave badly compared to other HPV, even though they're all oncogenic subtypes. So HPV 16 and 18, if you have an infection with either HPV 16 or 18, you have an up to 17% chance of developing CIN or more in 5 years. But if you test negative for any of the oncogenic subtypes, your risk of developing CIN3 or cancer is less than 1% in the 5 years of follow-up following one test. So this test tells us that, okay, if you have HPV negative test, your risk is low. You don't have to worry. So I'm just going to run through and explain. So if you test negative for high-risk HPV subtypes, it means that you are in the low-risk group and you do not need a repeat test in 5 years. Now, I always tell patients to come back in 3 years because it does take almost 2 years for most people to organize themselves to come back for a repeat test. And in the case of COVID pandemic, we've had a lot of women who've been scared to come out for the test. So if you say just repeat in 5 years, we may go past that safety period. If you have a negative test, you may have a subclinical Hpv infection. So what it means is that although you test negative, it does not mean you do not absolutely have Hpv infection. It just means that the viral count is low and you do not have a clinical problem. But it warrants a repeat so that the subclinical infection does not become a clinical problem. And like all tests, there is a small risk of false negative. So if you have abnormal symptoms, like the abnormal bleeding or smeary discharge, please do not ignore it because you had a negative test. You need to seek medical advice to make sure that you don't have an early cervical cancer or cervical cancer, full stop. But what does it mean if you have a positive HPV test? Okay, it does not mean you will definitely get cervical cancer. What it means is you have had a HPV infection, and your HPV infection is active at the moment. But most HPV infection will get better on its own without any treatment. But it is important to check that a HPV infection has not caused any changes in the cells of your cervix, indicating that you have CIN. And this can be done by just doing the pap smear or the liquid-based cytology, and it can be examined using a magnifying glass in a process called colposcopy to try and identify whether or not the cells have changed and you have CIN. Because true identification of this area then allows us to be able to treat the disease and prevent progression to cervical cancer. So how do we treat CIN? CIN is very easily treated and has been around for a long time. We can treat it by destroying it. We can destroy using cold, which is cryotherapy, or we can destroy using heat, which is diathermy. Or if we have a fancy machine, we can laser the changes. Or we can cut it out. We can cut a loop of the area of the cervix where the abnormal changes are, or we can use a knife and cut out the area. Or if you feel that your family is complete and you don't want to have these changes anymore, you can choose to have a hysterectomy. Remove the entire woman's cervix so that the abnormal disease is gone. And all this will help to reduce the chance of cervical cancer. However, even though we had screening for a long time and we've been treating CIN for a long time, we continue to have women presenting with cervical cancer. And that's because, A, people don't attend for screening. So we had to come up with a better strategy to try and prevent cervical cancer. So what is around is vaccinating against HPV infection. So that is another way of prevention. So HPV vaccination is available. It is one of the few vaccines that is available to try and prevent cervical cancer. And the first generation vaccine has been around since about 2005. and it protects against HPV 16 and 18, the two subtypes which are the most aggressive, which are responsible for 70% of cervical cancers. So if we have vaccination with this vaccine, you have protection against 70% of cervical cancers. And this data is true and applies worldwide. There is a second generation vaccine that is now available, and it protects against 7 oncology subtypes. And that's 16, 18, 32, 33, 45, 52, and 58. And if you have this vaccine, you then protect yourself against 90% of the cervical cancers. So actually, it can't get much better, really. Okay, we actually have a thing that if I give you this vaccination, you can prevent yourself from getting cervical cancer. So HPV vaccination is most effective in young boys and girls who have never been exposed to HPV. So maximum benefit gained by this group. And the first generation vaccine has been available to schoolgirls in Malaysia in an immunization program since 2010. And it's available for free. Currently, through our effort to try and eliminate cervical cancer, we now recommend HPV vaccination for boys and for men. For two reasons. One, it increases herd immunity. So therefore, as more people are vaccinated, less people will get HPV infection, and therefore less spreading around of HPV infection, and therefore faster elimination of the cancer. Secondly, boys and men are also susceptible to HPV infection type disease. So therefore, it is of benefit to them to get the HPV vaccination too. And lastly, we used to think that, okay, you've been exposed to HPV, there's no point you getting it. But there is actually evidence to show that even if you've been exposed to HPV, or even if you've acquired HPV-related diseases such as CIN, you will still benefit from HPV vaccination because it prevents reinfection, therefore further development of HPV illnesses, and therefore prevent cervical cancer. So with screening and immunization available, having cervical cancer is a crime. We should not have any more cervical cancer. So why does it still happen? One, again, I stress again and again, lack of awareness of one, that we have a cervix, two, that cervix can develop into cancer, and three, that there's screening or immunization available. The second thing that happens is social taboo. As I said before, cervical cancer happens because of infection with HPV, and that is acquired through sexual contact, genital contact. And a lot of women who are not married, or even young girls who are not married, are unwilling to come forward to say that they may have been exposed to HPV, and therefore they do not give themselves the opportunity of being screened. So we, as a society, have to try and work at eliminating the social taboo against premarital sex, so that women are prepared to step forward to get their screening. And there's no better time than Women's Awareness Month to promote this. So has our efforts actually made a difference? And the answer is yes. So on the graph on the left, we show that cervical cancer was the 7th most common cancer in Malaysia between 2007 and 2011. And through our efforts, the figures in 2012 to 2016 shows that cervical cancer is now the 9th most common cancer. So I do believe that if we continue with this, we will eventually eliminate cervical cancer, not only from Malaysia, but hopefully from the world. So what happens if you're unfortunate enough to develop cervical cancer? Well, the most important thing is to get the correct treatment, okay? And to get the correct treatment, you have to stage the cancer. Cancer comes in 4 stages, starting from stage 1, where it's confined to the cancer, to stage 4, when it has spread throughout your body. And we can stage cancer through radiology, and that includes nuclear medicine, which is a PET scan. And there's clinical staging, which allows us to examine the size of the cancer and assess the operability of this cancer. So radiological screening is very helpful to tell us that there has been no spread to the cancer. It is a must to be done before planning the treatment and definitely before instituting the treatment. So we do, for me, there are two types of screening. One, staging, that is using an MRI scan and using a PET scan. So on the left, we have a picture of the MRI picture of the cervical cancer, which is, as you can see, 4.9 centimeters. So this is a very big tumor. And by staging, this is at least 1B3. And big tumors have risk of spreading to lymph nodes and distally, so further. So we do a PET scan, and we show here on the right that there is no evidence of spread. The cancer is confined to the cervix, and therefore, we can therefore get the go-ahead to proceed with the operation. Sometimes though, we do an MRI and the cancer looks like it's completely confined to the cervix. And if we just take this as gospel and say, okay, let's treat the operation, we would be wrong, because if we did a PET scan, we then realize that the cancer has actually spread to the bone, and therefore doing an operation for this patient is not the best thing. So it is important to do the staging. And unfortunately, for a lot of women, if I tell them, you know, I shouldn't do the operation for you, it is not the best treatment, they actually see this almost like a death sentence. But it is not, okay? Because sometimes the best treatment is not always surgery. The clinical staging helps us determine if we can remove the cancer successfully through operation. And by this, I mean, when I cut out the tumor, the lines where I cut, there is no evidence of cancer cells. So if the cancer cannot be successfully removed that way, to say I can cut it out and then I give you chemotherapy or radiotherapy afterwards, I actually reduce your chances of a good prognosis, a good outcome, all right? So therefore, it is important to decide at the very start, should I be doing surgery or should I be doing chemoradiotherapy as a primary treatment? Because it does matter how you survive this cancer. So for me, if you get diagnosed with a cervical cancer, please seek a specialist opinion, a specialist who specializes in gynec cancer treatment to get the best outcome for you. So the takeaway message today, to realize our goal to eradicate or eliminate cervical cancer, please regularly attend cervical screening with the Hpv test. Hpv testing has now become the recommendation from MOH as the screening test for cervical cancer. Seek medical help if you have symptoms of abnormal bleeding or vaginal discharge that is smelly or even excessive discharge. Because you may not have a cancer, but it'd be good if you do have a cancer that we pick it up early. Vaccinate your children to protect them against Hpv infection and diseases related to HPV. It is not too late to vaccinate yourself to protect against HPV-related diseases and to prevent cervical cancer. Thank you very much.
Thank you so much, Doctor. I think lovely that you've managed to kind of compose this entire podcast into a very succinct presentation. And I think it's very beneficial for our viewers as well. Doctor, I've got kind of a group of questions. Are you okay a little bit for time?
Sure, sure.
Okay, so the pocket is between HPV DNA and Pap smear, and I'll do that first. And then there's a couple of interesting policy type questions that might be helpful to get kind of your input. Okay, so I love the fact that you started off the talk with the word cure. And that's not often used in terms of cancers, isn't it, Doctor?
Yes. I think it's one that where we detect early, we really do have a chance of cure.
Yep. Yeah. And actually, a lot of people have heard me say this as well. I'm so happy you echoed this, although I say it worse than you, in the sense that for me, we feel very stupid when we pick up a cervical cancer. You know, it means that the system has failed.
Yes.
Right. True, Doctor. Doctor, so this first series of questions is, what is the difference between a HPV DNA test and a pap smear? How often should we do both? And or either one, I suppose. And then what are the advantages of a HPV DNA test? So that's the...
Okay. So the HPV DNA test is actually looking for the HPV in this, the vaginal discharge, if you like. Okay, so we're looking for evidence of infection. And it is a test that can be done in several ways. One, some people can do it the same way you do a pap smear. Some people can do it in the same test that you do a pap smear. You can do the pap smear and the HPV test, which is offered by some laboratories. The HPV DNA test identifies the 14 high-risk subtypes, and it tells us whether or not you've been infected. Once we know you've been infected, we then want to know whether or not the infection has caused any change. So if you don't have any infection, you can actually be cleared to say you do not need a repeat test for 3 to 5 years. The evidence is 5 years, all right? You're okay for 5 years. But as I say, most people take 3 years and more than a year to get themselves organized to remember to have the test. So I always tell my patients 3 years, okay? So in this pandemic, it has worked out really well because it's taken them a whole year to come to the clinic, okay? Again, even if there's no pandemic, you're busy, you have a period, your doctor is away, you're going on holiday, you know, all these reasons, okay? So we often try to plan so that we don't miss out on a possible development of things, because there is nothing worse than having a test and then realizing that, oh, if I'd done it a bit sooner, I might have picked it up. So for HPV DNA test, the recommendation is between 3 and 5 years, up to 5 years, you're okay. The pap smear or the liquid-based cytology is a different test completely. So there we are detecting to see whether the HPV infection has caused change in the cells of the cervix. So basically, we are picking up the disease when it's already caused a problem, the infection when it's already caused a problem. If you look at the guidelines of recommendation, we do pap smear every 3 years. But I think most people, most doctors do it every year because we have this inherent fear that we may miss things, okay? We have an inherent fear that our report may not be as accurate as we like it to be. And, you know, we're a little bit kiasu as well. So we tend to do it a bit more frequently. So most patients, when they come and see me and I say, oh, you don't have to do this test again for 3 years, they have this sudden, oh my God, but my other doctor used to do it every year, okay? So the negative predictive factor is what gives us confidence to say, you are low risk. You do not need to repeat this test for 3 years. Yeah, have I answered all the questions?
Yes, you have, Doctor. Lovely.
Yeah.
Okay, and now this second pocket of questions, I think we have to break up the questions a little bit, Doctor. First question is, how do you see the acceptance level of HPV screening among different stakeholders in Malaysia, clinicians, policymakers, patients?
Okay, I think this is a problem that is a worldwide problem, if you like, okay? First of all, patients, they find it difficult to accept that this test that they've been having for so long, now I'm trying to introduce a different test, all right? And a lot of them think, oh, it's just a more expensive test, so therefore you want to make money out of this. But it's not true. It's a more accurate test. And science has proven this to be more accurate. There's less margin of error. So we have to accept science, all right? This is a test that is run by a machine, just like our COVID test, all right? This is a test that stands a trial of challenge, okay? Because we actually have to challenge our machine to make sure that it's actually consistently giving us the correct answers. So this is very important, right? For clinicians, I think that part of the problem about slow move towards HPV testing is the long time we spend on answering the questions relating to HPV infection, how we get it, how it affects the disease, what happens when it's negative, what happens when it's positive. And worse still, when you have one test that's negative and then you have a test that is positive, you then have to explain the dilemma to your patient that, okay, the test is now positive, and the immediate reaction is that the partner has been unfaithful. Then you spend the next 3 hours trying to persuade your patient not to kill the husbands. So one of these things is, some clinicians will just say, I'll just go with something that we've always used. But it's a less accurate test. It's less sensitive. So therefore, if we want to eliminate cervical cancer, if we want to promote acceptability, to try and make sure that cervical cancer is no longer a problem, then we need to use the better test. Okay. And lastly, the swab that I showed, it's probably one of the major breakthrough. Okay. A lot of women do not want to go for pap smear screening because they simply hate the intimacy of speculum examination, to look at, to visualize cervix in order for you to be able to get a specimen accurately. Some women, through religious reasons, some had bad experience, some have been raped, all these things factor. So the swab is a new thing, right? It is a swab that can effectively collect a specimen to give us an accurate result, just as we do collecting by direct vision, okay? And even better, you can do it yourself, okay? So you do not have to be examined by a doctor. You can actually do it yourself, okay? And I am very proud to say that Malaysia has this brilliant program at the moment called the ROSE program, which is going to different parts of Malaysia to try and get cervical screening up and running. More people have access to it, more acceptability, okay? And it's all true, promoting to them that, hey, this is not painful, you can do this, okay? And, we can get a result and we can tell you, you're okay, you don't need any further investigation. I don't have to do this speculum examination to look at your cervix. You are negative, you're clear, And I think that it is time that we actually move on with screening. And we are not the first country. I'm very proud to see that Malaysia has adopted HPV screening. Okay, but we are joining ranks with the developed countries like UK, Australia, US. And I think we should be accepting it.
Right. Lovely, doctor. There's okay. So right in that line of what you were saying, is there any way that we can further empower our women into making informed decisions? Like, how do we kind of convince them better? Any ideas, doctor?
Convince the women to have the test.
Yeah. On overall, I mean, on cervical cancer screening.
Okay. I think programs like this is good. Okay. And it's amazing how, through social media, okay, they may not have time to join us today, but, friends will tell them, oh, I saw this program, and they talk about this, and it does promote awareness. I think there's nothing more important than promoting awareness. And this day, it's all social media.
Right.
Yeah.
That it is, doctor. That it is. And I'm going to just take one final question, doctor, and as we wrap up your segment, in the cervical cancer elimination journey, prevention, screening, treatment, which area should be our key focus for the next 5 years?
I think prevention is very important. Immunization is probably the way to go, okay? The vaccine, as I say, is available in schools. Okay, and that's the first generation vaccine. The second generation vaccine is now widely available in Malaysia, and we are luckier than some countries in Asia because they don't have the second generation vaccine.
Right.
We have anti-vaxxers, and we have to try and promote this thing that actually it is a very safe vaccine. Nobody's died from vaccinating themselves against cervical cancer, but people definitely have died from cervical cancer. Okay. The other issue is cost, okay? This vaccine costs about 500 ringgit to get each vaccine, and it's about 3 vaccines each. And, when you explain the benefits to patients or people come to your clinic, they actually think, okay, actually, this is a good thing, I will have it, okay? And when some of them tell me, oh, it's quite expensive, I actually ask them, how much does your mobile phone cost? Okay.
5K.
Okay, so this is something that can prevent cervical cancer. Very small price to pay. Okay.
That's true. Okay, will do. Doctor, thank you so much for spending so much of time and patiently kind of going through all these questions.
Sure.
And you had a takeaway just now, and maybe you want to reiterate that for our viewers tonight.
Okay, I think we should, and anybody who has had sexual activity in the past, please attend for cervical screening. And that can be a HPV test that is now quite widely available and also actually available in our KKM screening clinics, I think. Please vaccinate your loved ones, okay? Your children, yourself, and your husbands, your partners. Spread the awareness, because through this tool, we can actually try and eliminate cervical cancer. Thank you.
Thank you so much, Doctor. Ladies and gentlemen, that was Dr. Chew Gee Keng, consultant gynecologist from Penang Adventist Hospital. So please tune in to kind of get rewatch this segment if you've missed this. If you're just coming in after dinner, it's on our Facebook as well as Penang Adventist Facebook. The videos are there for you to rewatch and re-listen to this very, very insightful discussion from Dr. Chew. Good evening, Doctor. Thank you so much. And coming into the third segment of this evening, this has been a very interesting evening, and we're very privileged to have with us as the third speaker for this evening, Dr. Ang Su Fan. Good evening, Doctor. How are you?
Hey, I'm fine. Thank you very much, Dr. Murali, for having me here.
Doctor, it's such a pleasure and a privilege for us as well to have you speak to us this evening. And Dr. Ong Su Fan, ladies and gentlemen, is a consultant medical oncologist with Penang Adventist Hospital. Doctor, I was going to ask you, are you originally from Penang?
Yes, I'm a Penang boy.
Oh, this one balik kampung lah. What made you come back to Penang to work? Was it the kway teow?
Yeah, char kway teow and durian, the Barlicula durian.
Oh, lovely, lovely. Thank you so much, Doctor. And just kind of an interesting question for our viewers, Doctor. What is the difference between, we've seen a lot of clinical oncologists, we've seen radiation oncologists, now we've seen medical oncologists. What's the difference between all these type of oncologists?
Okay, so clinical oncologist was originally trained in UK. So in UK, they have a clinical oncologist where they do both medical oncology as well as radiation oncology. All right. So I think when the time passed by, there are more and more challenging field in oncology and more subspecialized. So people divided into two fields: the radiation field and the medical oncology field. All right. So in country like in Japan, in US, right, in many part of UK, right, many part of Europe, right. So we actually divide, including Singapore. So we actually divided into those who do radiation and those who do chemotherapy, immunotherapy, etc. And
right.
So for me, I do not do radiation. I only do medical oncology.
Right. Lovely, Doctor. Thank you so much for sharing that kind of insight into what the different types of oncologists are and speaking about yourself as well. And ladies and gentlemen, this is really very opportune because we actually get a medical oncologist this evening who is an expert in the medical aspect of oncology. And Dr. Ang is specifically going to speak to you about the sexy new medicine that we always hear about now in oncology, which is immunotherapy. And in line with Ladies' Night, Dr. Ang is going to speak to us about immunotherapy in women's cancers. Doctor, over to you, Doctor. Screen's all yours.
Okay, thank you. So for those who still with us at this Ladies' Night, thank you for spending your precious time with us. Right. So in the next couple of minutes, I hope I can deepen your knowledge on immunotherapy, especially in women's cancer. Right. So immunotherapy, the discovery of immunotherapy really changed the way we see cancer, changed the way we manage cancer, and we must thank these two scientists, Professor James Eliason and also Professor Tatsuku Honjo. Both of them discovered immunotherapy. They are not the one who use immunotherapy to cure cancer. They are not the one who produce the drug to make cancer, but they are the one, the brain behind the discovery on why our immune system fail to detect and kill cancer cells, right? So they were awarded Nobel Prize for discovering immunotherapy. So if you know this guy, this is the ex-president of America. He was diagnosed with melanoma with brain metastasis. That was in 2015. And she was given this drug called pembrolizumab, and his cancer disappeared. That was back in 2015, right? So when I tried to Google his latest status yesterday, and I realized he's now 96 years old, and this is incredible, and he's free of cancer, right? And what impressed us the most is that he is the oldest president in America, and he's older than Dr. Mahathir. Okay, so in the last 1 decade, 2 decades, right, we begin to understand what is immunotherapy, why cancer just happens, right? And cancer happens for many reasons. For example, right, cancer cells, they can produce their own growth factor, right? They can stimulate themselves to keep growing, right? They are insensitive to anti-growth signals, right? They are quite resistant to the DNA stress damage, right? And they have potential, what we call immortality. They keep multiply without problems at all, right? And one of the reason cancer develop is because they evade our immune surveillance. So what is the meaning of evading immune surveillance, right? Okay, so I'm going to explain to you a short while, right? There are many remarkable achievements with immunotherapy in stage 4 cancer, right? And let me give you an example. How good is this medicine, the immunotherapy, right? So this is one of the studies using pembrolizumab with chemotherapy in treating stage 4 lung cancer. So as you can see, about 30% of patients, they live more than 5 years with this combination treatment, right? And this is something you never see previously, right, during the chemotherapy era, right? Another remarkable achievement is treating melanoma. It's a type of skin cancer, very, very bad prognosis skin cancer. Most people do not live more than a year. So this is where, this is the disease which the President Jimmy Carter got, right? So in these studies, again, it actually showed there is a significant number of patients who live for long term. Again, it's something that you never seen in the past, right? So what is cancer immunotherapy? There are many types of immunotherapy, but the one used away here, we use most of the time is what we call immune checkpoint inhibitors, right? And there are 3 drugs that are approved in Malaysia. And these include pembrolizumab, atezolizumab, and durvalumab. And these 3 are commercially available in Malaysia, right? How does immunotherapy work, right? So this is just a simple cartoon to demonstrate to you, right? In fact, our immune cell, our T lymphocyte, they have the ability to kill cancer cells, right? But some cancer cells, they are very smart, right? They produce a protein we call PD-L1, right? So this PD-L1 protein acts as a shield. It protects the cancer cell, right? And from the detection by the immune cells, right? This is what we call evade immune surveillance, right? So we use drugs, immunotherapy, to destroy or to block this receptor, like this PD-L1 receptor or this PD-1 receptor, right? And when we destroy or we block this shield, right, our immune cell, the T lymphocyte, it can detect and it can destroy the cancer cell, right? So in another word, our immunotherapy, the drug itself does not kill any cancer cell, right? Instead, it stimulates the immune cell to kill cancer cell. So, and this is very different from all other treatments, all right? Whether it's targeted therapy or chemotherapy, where it acts directly on the cancer cell and it causes the cell to die, all right? Okay. So in fact, how immunotherapy works is not as simple as I told you just now, right? It is a very complicated process, right? It first started with some cancer releasing some antigen. It was detected by antigen presenting cell. It was moved to our lymph nodes, right? It was detected and get the T cell get activated, right? And then there's interaction between the PD-1 and PD-L1, right? And this lead to some cytotoxic activity, right? So it is not as simple as what I told you, right? Okay. So in this presentation, I will concentrate on women's cancer. So in Malaysia, immunotherapy for women's cancer is approved for the use in breast cancer and uterus cancer, right? As we know, breast cancer is the top cancer among female, account for 1/3 of all female cancer. So in fact, uterus cancer also is quite common, all right? Top number 6 in the top 10 list among female, right? So my talk will be more on uterus cancer because this is the only approval for women's cancer besides uterus cancer, right? So when we say uterus cancer, right, usually we refer to endometrial cancer. Endometrial cancer arises from the internal lining of the uterus, which is the endometrium, right? So any part of uterus can become cancerous, right? For example, the muscle in the uterus can become cancer as well. And this is uterus sarcoma, which we are not going to discuss, right? The most common symptom that when we have uterus cancer is abnormal menses, right? And for those who have menopause, they will get what we call postmenopause bleed. For those who are premenopause or perimenopause, they will develop what we call irregular heavy bleeds, right? And these are the two conditions they always go to see their gynecologist, right? Okay, so the gynecologist will do examination, ultrasound, laboratory tests, including the cancer marker CA125, and they may do hysteroscope to visualize the internal part of the uterus, right? And they may need to get a biopsy, all right? If they suspect, if they think it's cancer or confirms cancer, then we need to do a CT scan or MRI to stage the cancer, right? In the past, right, we divide uterus cancer into type 1 and type 2. Type 1 is happen to those who are obese, those who have a high estrogen, younger age, right? And these are group of uterus cancer that have better prognosis. In contrast to the type 2 that occur at older age, right? Usually in the teen patient, they have the worst prognosis, right? Okay. So it is very important to understand how this uterus cancer spread so that you will know how we can manage this, right? In the earliest cancer, stage 1 cancer, the uterus cancer, endometrial cancer is only confined to the uterus itself. Okay, so this is stage 1. When we say stage 2, right, it actually extends to the vagina, to the cervix, right? When you say stage 3, it actually extends outside the uterus, right, into the fallopian tube, into ovary, or into the vagina, right? Because this is considered stage 3, right? In a more advanced stage 3, you go to the lymph nodes, which is something that we do not like, right? And of course, when you say stage 4, right, if the cancer, we leave it alone, right, we didn't do anything, it keep growing bigger and bigger, you're going to invade the bowel, the bladder, you know, right? And it is bad. It can cause fistula, right? Okay, and also when it spread to other places, right, in the body, to the liver, to the lungs, right, and this is called advanced stage 4 uterus cancer, right? So this is how we treat the uterus cancer, right? We always want to perform surgery to remove the uterus, the ovary, the fallopian tube, as well as the cervix, right? So and in more advanced cases, right, we also want to perform lymph node dissection, right? So after the surgery, the earliest stage, we may just give a bit of brachytherapy. Brachytherapy means we insert radioactive seed into the stump, the vaginal stump, to prevent local recurrence, right? So when you move to stage 2 or stage 3, we may need to include radiation. And for more advanced disease like when it's lymph node involvement, we also want to include chemotherapy to this group of patients, right? So we are not going to discuss in detail the management of early stage cancer. Today, my concentration will be on the stage 4 uterus cancer, right? So fortunately, most patients with uterus cancer, they were diagnosed at quite early stage, although some present with later stage and some does recur and become stage 4, right? So when we have stage 4 cancer, any cancer, right, we must understand our treatment goals, right? And our treatment goals, number one, is the hope to control the cancer. You want to shrink it, reduce it to control the cancer so that it doesn't spread further. Hoping by doing this, we can reduce the symptoms as well as prolong life, right? Okay. So generally, most stage 4 cancer, we are not able to cure them. Of course, there are a few exceptional cases with very limited or we call oligometastasis. We may do certain procedure like surgery or radiation to get rid of these oligometastasis, right? And there's still a chance of cure, right? Okay. So for stage 4 cancer in the past, all right, we do use hormonal treatment. In fact, we still do this now, and they are still part of very important treatment for advanced stage 4 uterus cancer, right? So for some cancer that express hormone receptor like the estrogen receptor or progesterone receptor, exactly as what we see in breast cancer, we can use that hormonal treatment like tamoxifen. It does work for this group of patients, right? And for most patients, we actually will give them chemotherapy with drug we call paclitaxel and carboplatin every 3 weekly for about 6 cycles, right? And this is a standard of care today, right? Okay, and in the past, right? In Malaysia, in fact, the immunotherapy for uterus cancer only approved this year. So before this year, we only talk about chemotherapy for uterus cancer, right? So until this year in 2019, FDA, the US FDA approved this combination pembrolizumab plus lenvatinib to treat advanced endometrial cancer, right? So pembrolizumab is a type of immunotherapy and lenvatinib is a type of targeted therapy, right? So it was approved in 2019 in Malaysia. I think it was approved early this year or end of last year. Okay. So how these two drugs work, right? In many occasions, right, immunotherapy we do not use alone, all right? We always like to combine with some other partners, right? For example, we combine with chemotherapy. Sometimes we combine it with targeted therapy, right? So immunotherapy, I explained to you how it works. It actually inhibit the receptor, the PD-1 or PD-L1 receptor, so that it actually break the shield that protect the cancer cell, so that our immune system can detect and destroy the cancer cell, right? Okay, so it is very important to understand this concept. Okay, so we get cancer not because our immune system is weak. It's not, right? It's because of certain mechanism that allow the cancer cell from detection by the immune system, right? It's not because our immune system is weak. It's not, right? So you think you buy some herbal product or some this supplement product that can say, oh, it can boost your immune system and can kill cancer cell, right? That is not true, right? Okay. Lenvatinib, on the other hand, is a type of target therapy, and the function is to block new vessel formation in the tumor, inside the tumor, right? So when the tumor wants to grow, you need vessel to feed them, all right? So you block this vessel, the tumor cannot grow, right? Okay. So how good is these two drugs, right? Okay. The beauty of immunotherapy, as I show you in the lung cancer and in the skin cancer study, is that you see significant long-term survival, right? So in this case, right, we do see significant amount of patients, right? About 30% of patients, they live more than 2 years, right? Of course, this study is still early to tell us what will happen after 5 years. It's still too early. but at least we know many of them can live for more than 2 years, right? And this is a very remarkable achievement. And we wait for more studies and more matured result to come, right? Okay, I want to explain a little on what is targeted therapy, all right? So targeted therapy, they are actually medicine, drugs that used to target a certain protein, certain receptor that actually causes the cancer to grow, right? For example, in some style of lung cancer, you have a mutation that causes what we call EGFR mutation, right? And this EGFR mutation, it'll cause the cell, cancer cell to grow, to keep growing, and by blocking this receptor, right, we can actually prevent the cancer from growing, right? Okay, so there are many types of immunotherapy, right? So and they work differently. Okay, they block certain molecules, certain receptor. So and eventually they'll result in you'll stop the survival of the cancer. They'll stop the building of new blood vessel, angiogenesis being a new vessel formation. So they'll block the blood vessel formation, right? And with the hope that we can stop the cancer from growing, right? Okay, so in the past, as I told you, we have type 1, type 2 cervical cancer, but now it is quite meaningless to classify in that way. Now we classify cancer based on their genetic, based on their molecular profile, right? So in uterus cancer, and this is how we classify, divided them into 4 groups, right? The pole, the MS. So, and only one group that I would like you to pay attention, it is the MSI high group. So what is MSI high? This is a very important terminology that we need to understand, right? Okay. So many oncologists will ask patients to check the tumor for a genetic mutation called MSI. MSI, or microsatellite instability, it happens because of mutation in DNA mismatch repair gene, right? So what is this, right? Okay, you see, our DNA in our body, right? Damage will happen, right? It's like when you copy a file into the hard disk, right? There's error in copying file, but the computer have a system to correct the error. Similarly, our DNA, when you need a mechanism to repair the DNA. When you cannot repair the DNA, right, the DNA become damaged, and the more and more damage will accumulate, right? And this is what we call macrosatellite instability, right? So when you have a lot of mutation, right, it can lead to a few cancer. For example, colon cancer, stomach cancer, and endometrial cancer, right? Okay. So this MSI test, right, if it's positive, is a predictor for a better response to immunotherapy, right? Is MSI good? Well, it's not good, because if you have MSI, you have a higher risk of getting cancer. But if you have cancer, it is a better thing, because it means that the patient can respond better to immunotherapy, right? So, and this is a study actually showed, all right, for those patients who have MSI high, all right, MSI high meaning they have abnormal MSI, right? So you can use this immunotherapy to treat this cancer, and it works pretty well, right? And FDA actually approved this immunotherapy for the use in patients with the abnormal, the mismatch repair protein, or we call it MSI high, right? Okay. The problem with this treatment is that it is very unreachable for most people, most cash-paying people, right? Lenvatinib is a C4 bomb. Immunotherapy is an atomic bomb, right? If you combine both these bombs, I don't know what bomb you want to call it. It is extremely expensive, right? So it causes great financial stress to patient, to the family, to the health institution, to the country, as well as to the medical insurance company. And the treatment is going to be more and more expensive in the future when there are more and more new drugs. Right? So this is the biggest challenge when it comes to this good but expensive treatment. Right? Okay, targeted therapy, they are different from chemo. They rarely cause like hair loss, nausea, vomiting, you know, they rarely cause that. But they can cause some rare side effect like hand-foot syndrome, right? And this is grade 3 hand-foot syndrome. So this is one of the worst side effects with this drug. Unfortunately, it's not that common. But if we have to educate the patient properly how to take care, moisturize their hand and feet, right, to prevent this. You can see blister, you can see the skin is cracking, very dry, right? Fortunately, it is not common and it is treatable. You can give a bit of steroid cream. And most importantly, we have to prevent this by applying a lot of moisturizing lotion, right? Immunotherapy, so we know immunotherapy, the drug stimulate the immune cell to attack cancer cell, right? Sometimes these immune cell, they go crazy, right? They go attack the normal cell, right? So they go attack the skin, they go attack the joint, go attack the thyroid, attack the liver, attack the heart, can attack any organ. Fortunately, they are rare. These side effects are rare. If they come to see us early, the treatment is very easy. We give us a bit of steroid, it suppresses the immune cell, right? It will be easily treated, right? And patient have no problem. Right? Okay, so this is my last slide. In summary, early diagnosis of any cancer is equal to cure. Right? Early uterus cancer, in fact, in early cervical cancer, right? As well, early uterus cancer surgery awaits the treatment of choice, and they may need a bit of brachytherapy. Right? More advanced cancer, they need chemotherapy. For stage 4 cancer, the treatment is palliative intent with the intention to control, prolong life, minimize symptoms. Right? And now we have targeted therapy plus immunotherapy, which is a standard of care for the treatment of stage 4 endometrial cancer. Thank you very much.
Thank you so much, Doctor. Very, very concise, but I think you gave us a lot of interesting information, Doctor. I wanted to check with you. Are you okay for time? There's a few questions that has been put out. Okay, lovely, Doctor. There's one immediate question that comes is immunotherapy safer than chemotherapy?
Okay. Generally, immunotherapy is very, very, very well tolerated. Most patients do not complain, all right, except the price. All right. Okay, and the only side effect we always worry and we always want patient to know, identify it, and come back to see us early is the autoimmune disease. All right. As I told you, it can cause pneumonitis, the inflammation in the lung. Patient can shortness of breath, get cough. It can cause very bad diarrhea because it attacks the bowel. Right. It can cause colitis. So when you have this symptom, I always tell the patient, you must come back to see me immediately. All right. Right. Or the next day. All right. It's very easy to treat this side effect. Just a bit of steroid, then this thing will resolve most of the time. All right. So as compared to chemotherapy, of course, the side effect of chemotherapy is there. It is very manageable nowadays. For example, hardly people vomit anymore because they have very good anti-vomiting medicine. Right? And a bit of nausea, which is very, very mild for most patients. So certain drugs in chemotherapy cause hair loss, right, which is unpreventable, unfortunately, right? So a bit of tiredness, a bit of fatigue, a bit of loss of taste, you know. So a bit of neuropathy, numbness in the hand. Sometimes it happens, right? Of course, rarely you see very bad side effect. Patient come with fever, with septic infection, right? With low white cells. So this thing happen. It can happen, right? But we have to identify this. We can manage it. Then we guide the patient through their journey with all this treatment.
Right. Well do, Doctor. Thank you. There's okay, and I think this is maybe another very similar question to what you already were talking to us about, and maybe we can just kind of put it a little bit more in another way, because the viewer is asking what happens during immunotherapy treatment.
Okay. So immunotherapy, generally they are given every 3 weekly, right? Some are given 2 weekly, but most are 3 weekly. It's given, the way it's given is by infusion. It's not oral, it's by infusion. It's drips, right? It's given over 1 hour. All right. So in the morning, patient come for some blood test and they see doctor. All right. They go for treatment, infusion, right, in the chemo center. All right. Then they go home. All right. Like 3 weeks later, they come back again to see us. All right. So this drug generally we use to treat stage 4 cancer, right? Although they are immunotherapy now, we use to treat stage 3 cancer, like durvalumab for stage 3 cancer. So generally for stage 4 cancer, right, our aim is to control the cancer, right? After 3 or 4 cycle of immunotherapy, we always want to scan the patient, right? Do a scan again, restaging scan to make sure that cancer has become smaller, right? Patient symptom is better, right? Every time we see patient, we want to make sure their symptoms is better. Sometimes we do a cancer marker as well. If the cancer marker is high, right, we can do cancer marker. We see, make sure you drop, like CA125, right? You keep dropping, you know, it's a good sign, right? But after all, we will make sure it works. Then we will continue, right? So the question, how long we continue immunotherapy, right? Generally, we do not stop, right? We continue, right? So for most cancer, we do not stop. I have patients who on immunotherapy for 2 years, for 3 years, we continue, right? Although there are studies say that if the patient cancer completely resolved, right, disappear, right, you may stop at 2 years, right? If the cancer come back again, you may restart back again, right? But most of us actually not very comfortable doing so, right? So usually we do so for cost reason.
Right. Right. And I think the cost is something we all need to work towards, Doctor. Doctor, there's just one more question, and just before we wrap up this segment tonight, and this is in late stage cancers of I assume they're talking about gynecological cancers. When they don't operate, how are we going to send the markers to find out whether we are suitable for immunotherapy?
Okay. So immunotherapy for gynecological cancer, the approval, the indication is for stage 4 cancer. Okay, so you need to make sure. First, of course, you need to be certain what cancer the patient has. So whether it is cervical cancer, whether it is ovarian cancer or uterus cancer, right? You always start with some biopsy. You always need biopsy, all right, to confirm what cell is that, right? So after the biopsy, you need to do scan, all right? Sometimes we do PET scan, all right? So when we notice that the cancer has spread out of the uterus to the lung, to the liver, to the bone, right, or to lymph nodes outside the pelvis, right, or further away, you know this is stage 4 cancer, and this is the place where we use chemotherapy or immunotherapy, right? So in uterus cancer, the first line is always chemotherapy, right? Immunotherapy is the approval so far is on second line, right? I'm sure there are trials ongoing that will study the role of immunotherapy in the first line setting, but this is akan datang, not for this moment.
Right. Right. Will do, Doctor. Thank you so much, Doctor. I think this has been really a very insightful talk as well. It's been a good ladies' night. So it's time to close up the lounge and let everyone go home.
Yes.
But just before that, I was going to ask you if you would be able to give our viewers a last takeaway for tonight.
Okay. Yes. So to all ladies in this ladies' night, please take care of ourselves. Good diet, good exercise, right? Take care of our psychological aspect, right? And if you have an alarming symptom which is lasted more than 2 weeks, always seek to see a doctor, right? And you must see the correct specialty, get a correct test done, and do not fear, right? Do not fear because of this social taboo, because of we worry that we may get some bad disease, right? We shouldn't feel so, right? Because when we are unwell, get a treatment given, and any disease, when it's diagnosed early, is cured. Thank you.
Right. Thank you so much, Doctor, and a very good evening as well. Thank you once again, really, for this wonderful session with us. Ladies and gentlemen, this was Dr. Ang Su Fan, Consultant Medical Oncologist at Penang Adventist Hospital. With this, we'd like to wrap up this evening's session of Cancer and I, and it's been wonderful to have you all, and as well as our partners, Penang Adventist Hospital for this session, and of course, our major partner, the Roche Group, which has supported Cancer and I, comprising of the pharmaceutical, diagnostics, and shared services arms of the entire organization. So thank you very much, and we will see you soon with the next edition of Cancer and I. Until then, to all ladies and of course you gentlemen listening as well, a very good night.